Hi everyone, welcome back to the OT Miri channel. My name is Miri. I'm a licensed occupational therapist, and in today's video, I have a very special guest with me today, Dr. Michael Lang, who is not only my former OT instructor at USC, but also my instructor for the Certified Neuro Specialist Institute. So needless to say, he is a wealth of knowledge when it comes to evaluating and treating neurological conditions. And I am so very honored to have him here with us today to share his perspectives. Now, today's video is going to be part of the stroke series that I've been doing. So if you haven't watched part 1 or 2, I want to encourage you guys to check that out first because it lays the foundational knowledge. And you'll be able to see how that knowledge translates to real-life situations that Dr. Michael Lang will demonstrate today through a case study. And if you've already passed the exam, you know that textbook knowledge doesn't always translate in the clinical setting exactly the way we learned it in school. So it's always nice to get a clinical perspective and demonstration from a therapist working with a patient. So this particular video that we're doing today is more for all you practicing therapists who have been asking me to do a video on real life application demonstration. And for that reason, I'm really so very grateful that Dr. Michael Lang has given us his time and energy to put this together. So with that, I'm going to turn it over to Dr. Michael Lang to introduce himself as well as the patient he'll be working with for the case study.
Hi, Miri, and everyone watching OT Miri's channel. So excited to be here today to have this discussion with you about neuro rehab interventions. So just a little bit about myself. I am currently a professor at West Coast University's Occupational Therapy program in Los Angeles. I am also one of the instructors at the Neuro Specialist Institute. As Miri mentioned, the Institute is responsible for the continuing education course Certified Neuro Specialist, also known as CNS. And I've been in OT for, I don't know how long now, probably almost 15 years, I want to say. And I was also a former professor at the University of Southern California. And Miri, I guess that's where I met you almost 10 years ago.
Yeah, that's right.
All right, everyone. So we'll get started with our case study here. And our patient that we're going to show in the video today, his name is Raymond. And Raymond is a 28-year-old male who had a stroke while working out in the gym. And you might feel like, wow, that's really young to have a stroke. And what we're starting to see these days is it's starting to happen while the person is younger and younger. So something to be careful about. So after his stroke, our patient presented with some left side weakness, specifically in his left arm. He had some spasticity going on there, which really impaired his grasp and release. He also has some difficulty with eye movements, particularly with his tracking, also some difficulty with cognition when it came to his memory and concentration. So some of the goals that we really want to work on in therapy is to improve his gait, improve his upper extremity movement. His personal goal was to return to graduate school and to ride his motorcycle. So happy to show you guys this video of some of the interventions that we've used on our patient here.
Hello everyone, I am Michael.
And I'm Patricia.
And we are occupational therapists and certified neuro specialists from the Neuro Specialist Institute. And we're so happy to join you here today to show you some interventions for stroke. So let me share my screen and this video we have for you. So you already have the background information about our client. And before we get hands-on and start moving him around, I just wanted to do a general assessment in terms of his movement. So as you can see here, he has a what looks like a functional right side, but he has an affected left side. It looks like spasticity, but we can't know for sure until we actually start to move him around. So as you can see here, he can move his right leg. He's having some limitations there with his left. Now I'm going to take a closer look, and one of the first things that I want to do first before I start to move my patient or ask him to move that extremity is I want him to get into a better posture. So you can see there, all I simply had to do was engage his core muscles. On my right arm, I'm basically on his back, his erector spinae muscles, and I'm trying to facilitate a little bit more trunk extension. If he was having some difficulty there with a rounded back and shoulders, then I would be under his clavicle just to bring him into a little bit more external rotation as well. So continuing on with the assessment, I'm assessing what his scapula can do in addition to the movement at his humerus. So one of the first things that I'm noticing is he's coming deeply into internal rotation, which is going to affect the amount of shoulder flexion that he's able to do. So one of the first things I want to do is bring him out of there, bring him out of internal rotation towards more external or neutral, and to assess how his extremity moves from there. At this point, patient's saying that he's feeling okay, not really having any pain. So once again, bringing him into external rotation, making sure I'm visually seeing if the scapula is moving with this humerus. And in this next portion, I am assessing his spasticity. So what you're seeing me do here is a velocity test, and this is to determine whether or not our patient has spasticity. As you recall, at the start of this video, when the patient was in this position, just because he's in this position doesn't necessarily mean that he has spasticity. I need to test that out first, because the main distinction between hypertonicity, just meaning that you have very tight muscles, that's hypertonicity, versus something like spasticity, is that spasticity is velocity dependent. So the faster I move him from flexion into extension, the worse his spasticity is going to get. So you can see as I moved him from flexion to extension, it started to catch at about 90 degrees. That's where it was triggered the most, which to me as a therapist tells me that if I'm going to do any type of movement with him, we have to go slow, because the spasticity is going to get worse with faster movement. So you can see here with the slower movement, I'm able to bring him into more extension at the elbow, and I can actually get him to weight bear using his left arm on this mat, doing the same thing with his postural control, bringing him once again into external rotation, trying to fix that posture, mimic what he's doing on the opposite side. So looking good there in terms of his extension. I'm now asking the patient to move his humerus into shoulder flexion as much as he can. Once again, trying to see if his scapula moves with his humerus, and it does, so I'm not having a whole lot of concerns there. But what I'm going to do next is help move that scapula into upward rotation without really touching the humerus, and we're trying to see if he's able to get more movement. So patient is volitionally moving his humerus, and all I'm doing is I am just helping that scapula go into more upward rotation, and comparing this now at this phase, he is significantly higher than the 90 degrees that he was before. And of course, if you wanted to move him passively, by all means, you can do so. The most important thing is to, once again, reposition him, make sure that the scapula is moving with the humerus, and get the patient to do as much as he can first, and then you can help him out passively. He's shaking his head no, he's not having any pain, he's feeling comfortable. So this is something that we would probably work on in therapy. Okay, so before we get to ADL training, Patricia, I want to ask you a little bit, so what did you learn in terms of ADL training for the stroke population in your academic program?
Yeah, so let's say if they have weakness on one side, typically if you are teaching them how to don, let's say a shirt or a button-down shirt, you would teach them to thread the affected side first, and then having them bring it over towards behind them, and then thread the unaffected side.
Okay, so basically what you explained there was hemi-dressing techniques, right? And this is something that we really want to highlight and bring up, because depending on your training, where you might work, what other certifications you might have, there are some therapists who are, 100% okay with doing hemi-dressing, which is something that we would consider to be compensatory. And there's other therapists out there who are totally against it. It is not what they would consider to be normal movement. It's too much compensation. However, I think that there's always going to be a fine balance between what is normal movement versus what is functional. So let's take a look at our patient here. So he's going to do the hemi-dressing techniques that Patricia described. He is donning that affected side first. But you can see that he's having some difficulty, and this is where maybe as a therapist you might want to try to provide some assistance. So Patricia, what would you do, or what were you taught in your program in terms of providing assistance at this stage?
Yeah, so as you can see, the jacket is getting caught towards the elbow. So at that point, I would probably help thread that side all the way up to the shoulder. And then since it's all the way through the affected side, hopefully he is able to reach with his non-affected arm, bring it over his back, and then thread that side through.
Great. So that's one way a therapist can assist. If the patient is having difficulty moving that across his own body, then the therapist can assist by manipulating the actual jacket in question here. Another method we can do is to once again facilitate the movement instead of actually manipulating the tools involved. So what's happening here is I'm going to once again get the client to fix his posture. I am going to ask him to extend his elbow as much as he can. And once again, I'm going to try to move slowly. I'm going to try to facilitate there at the triceps, bring him back into external rotation. Now I have him in a more extended position. And me as a therapist, I'm not touching that jacket. That's going to be left to my patient. That's going to be his responsibility. I'm just helping with the movement. And now my patient has the means to dress himself a little bit more independently. So if you're the therapist who wants to assist a patient with the jacket, that's perfectly fine. If you want to take it into another perspective and help the patient with movement so the patient can don the jacket himself, that's also totally okay. Once again, it's going to be a fine balance between what is normal movement versus what is functional. And we want to keep that in mind as we try to be client-centered OTs. Thumbs up there from our happy patient. All right, so let's take a look here in terms of lower body dressing for the socks. So Pat, can you chime in a little bit in terms of how patients should be hemi-dressing using socks?
So to don a sock, typically you would have them use their unaffected hand, almost cupping it in a way that looks like a sock aid, and having them thread that through the sock and then bringing that hand to their affected foot to don the sock.
Great. And once again, that is hemi-dressing techniques, something that is very compensatory because they're only using that non-affected side. So what we're trying to do here is I'm trying to see, can he use both his hands? Can we facilitate more normal movement? And as you can see here, he has both his hands on the sock. I was able to do some hand over hand in order for him to grab that sock. But as he's reaching down, you can see our patient struggle. He doesn't quite have the motor control. Even though we got that arm extended for him to reach down towards his foot, he's still having some difficulty. So once again, still doing bilateral integration, still trying to have him bend forward to put the sock on. We're kind of a little bit successful there, but he was actually starting to complain of stiffness and pain on that left leg of his. So probably not the most opportune time to do this. Now we are going into the hemi-dressing techniques that Pat just described, and we'll see if he's able to do this method. And he was actually quite a bit more successful. He's actually getting the sock on. So once again, not to really advocate for one way versus another way. As a therapist, you're going to have to make that clinical judgment. Will my patient benefit from hemi-dressing techniques, something more compensatory? Can we do hand over hand? In the case of our patient here, he is living by himself. There's really no one to help him, and to try to make him as functional as possible, we have to introduce some compensatory techniques, and there's absolutely nothing wrong with that. Alrighty, so our next section, we're going to watch our patient do some electrical stimulation. Patricia, what have you observed in terms of e-stim with your stroke patients?
Yeah, what I've seen in the clinic is a lot of times therapists will just place the electrodes on the patient. Let's say they want to facilitate knee extension. They're sitting in a wheelchair, they place the electrodes on their quadricep muscles, and that machine is just basically moving them into that extension flexion movement without really doing anything else. They're just sitting and doing that modality.
So very, very passive type of application if the therapist makes it a very passive activity. I can't tell you how many times I see a patient just sitting there and the wrist is going up and down, probably 1,000 times as the therapist is doing something else entirely, not even engaging with the client. So if you're going to do electrical stimulation, we want to make sure that it is, number one, really engaging, and number two, something that is functional so that they have carryover with other activities. So an example of this is what we call a self-triggered electrical stimulation program, which you're going to see very shortly. I'm basically asking the patient, can he extend at the elbow and can he open his hand? And if he's not able to, then that is the only time where I initiate the device, where I trigger the device for him to go into elbow extension, and when I trigger it for him to open his hand and have finger extension. But the most important thing is to allow the patient to attempt that movement first. So here, he's not able to extend his fingers. That's when I trigger the device again, and we have that nice finger extension. I let go of the device and just have the patient do his own volitional movement. His flexors are fine. If his flexors were not fine, we would trigger for flexion, but he's able to do that on his own. So now I'm going to ask him to put the cup down. Once again, he's now having some difficulty with extension at the elbow. That's when I trigger and have that machine elicit that movement, and ask my patient to extend his fingers if he can do it on his own first. If he's not able, that's the only time I trigger the device. And what's nice about something like this is at some point I can train the patient to use the device on his own. So I can hand this over to him. I can say, hey, anytime you want to initiate movement using the machine, then that's when I want you to trigger. But again, I want you to attempt to do it first. If you can't do it, then that's when you would push the trigger. So give your patient the ability to do that on their own, and it just becomes a more volitional activity. He's not saying any pain. He likes it. It works out for him. All right, so our next section, we're going to be talking about orthotic devices, or in this case, splinting for the affected hand. So Patricia, what did you learn about splinting the affected side in your academic program?
Yeah, typically if they need a orthotic device, we usually just typically prescribe like a resting hand splint or even an anti-spasticity cone splint.
Yeah, and the thing about the splinting for the affected side is it's very controversial. If you think about what a functional hand splint looks like, it brings you in this, what we call a functional position. This is just so that if somebody has a lot of spasticity, and if you're running the risk of contracture, when you remove the splint, at least they have this position so that they can grab things, they can hold things. But if you really think about it, is this what is truly functional? Do we walk around with our hand in this position all day long? We don't. We flex, we make fists, we go into a hook grasp, we have a variety of different grasps. So if you were to prescribe a device, I would suggest it to be something a little bit more dynamic, a little bit more functional. So let's take a listen as to what our patient's experience with orthotic device is.
All right, Ray. So tell me a little bit about your history using splints for your hand.
Yeah, I used to go to a therapist and he prescribed me a splint to wear at night whenever I sleep, but it was very painful and dull and uncomfortable, so I just decided not to wear it after like a week because I couldn't bear the uncomfortableness.
Okay, so you don't wear it now, you stopped wearing that after a week?
Yeah, I don't, unfortunately.
Okay, and could you describe that splint for me? Was it like more of a hard type of splint or was it softer?
Yeah, it was very hard.
Very hard, yeah. Okay, like you couldn't move your fingers inside?
Yeah, it was not comfortable.
Gotcha. Okay, well if you're open to it, I haven't decided whether or not it would really benefit you, but there are devices out there that have more elastic properties, so if your hand at nighttime happens to close, something like this might spring it back into extension. But once again, I don't necessarily want you to wear an orthotic device during the day when you can be doing a lot of functional activities with your hand to help rehabilitate. At nighttime, if it was giving you some discomfort, maybe something like this would be helpful.
Okay, I'm willing to try it out.
Cool.
So as you heard from our patient's testimony, he tried a splint before. It wasn't really working out so well, which is why we want to give him a device that had more elastic properties. Unfortunately, we didn't have a device that was appropriate for him. The one that we had there was a right-handed splint, and he needs one for his affected left-hand side. But here in this video that we're about to play, we're going to show you another type of device that has more dynamic properties. You can see that I have some straps attached to the digits, and I can actually pull them back to help facilitate more extension. So if he has that tendency to go into flexion, the elastic properties will once again help him with that. And he's going to reach for a ball. He's using his own flexors. And now I'm asking him to use his own finger extension in order to release that ball. And because of the orthotic device that has that elastic property, we're able to do so quite a bit more effectively. All right, in this next section, we're going to talk about visual tracking and exploration. As you know from the case, our patient has some difficulty with his ocular motor movements. So in terms of that, Patricia, why don't you tell us a little bit about what you've learned in your program for visual tracking?
Yeah, so let's say they have those ocular motor deficits and they're having trouble with scanning or tracking. Let's say, for example, they have difficulty with reading, then we can teach them some type of compensatory technique where they are using their finger to follow along a sentence, for example, so that they're able to stay on track. Or use some type of blocking technique where we are using like a paper or a ruler to block out those lines that they are not reading so that they are able to follow along correctly.
All right, so we'll talk about those interventions that Patricia mentioned a little bit later on. Let's take a look and see what he was able to do with this visual tracking and exploration.
For this activity, we are having him touch the stop sign using his left side. And I'm having him try to reach for that stop sign and touch it as much as he can. And I am providing facilitation as needed. So if he is unable to reach forward enough, then I am using my hand to bring that scapula into more protraction and upward rotation. And also having him go into more external rotation if I'm noticing he is going towards that internal rotation position.
What's really great about this activity is we're utilizing a larger screen. We're really trying to get our patient to move. It's not just about staying stationary in one place, which is why at the beginning of our slide, you saw that we are combining visual exploration with motor coordination and also cognition. And we're really trying to get him to move around, really trying to get him to walk and balance and use that upper extremity. So on this slide, we're asking the patient, what was the speed limit on the previous slide? And that was something that he probably wasn't paying attention to. He was only looking at the stop sign. And this is where the cognitive component comes in. Like, how many distractors can we put in there? How many things can we put in there that's actually relevant? This is somebody who likes to ride motorcycles. These are all the different things that he needs to pay attention to. Is he able to not only track, but is he able to remember and pay special attention to the things that he really needs to? So as we continue on with this, we're going to explore other exploration activities.
Yeah, so for this one, we are having him follow the red line, going from number 1 all the way to number 2. So he is utilizing a green laser and having him follow with that tool. And this allows for him to use some visual tracking, also involves some motor coordination and also somatosensory components.
Yeah, and if you really want to challenge this somatosensory as well, in this case, we're using a laser and all he has to do is just move from one side to the other. If you wanted, as Patricia mentioned, he can use his finger and follow along from number 1 to number 2 and really engage somatosensory even more. So how you want to edit these activities and really challenge your patient, that's going to be completely up to you.
So I'm using the red laser to demonstrate the type of movement I want him to do. And as you'll see later on, if he needs cues to do the activity correctly, then that's where I'm using that red laser to guide him. But for the first one and then the second one here, he's able to follow from number 1 to number 2 on a red line pretty well. He's able to do it independently, actually. But for this third one here, you're going to notice that he is going to have a little bit more difficulty. He is following number 1 to number 2, that's correct. However, he is not following on the red line. He was following on a blue line. So here I'm using the red laser, guiding him towards which direction to track and follow, and giving him that cue to follow along towards the right path.
This is where it's getting really complex.
Yeah, exactly. So this one, he is following a red line, but he's going from number 1 to number 1 and not from number 1 to number 2. So here again, I'm using that red laser to guide him towards the correct path.
And that's the thing about challenging your patients, right? If they're easily distractible, then what you might want to do is minimize the amount of distraction so that they can really focus. If they're a little bit higher level in terms of what they're able to filter, then you can grade up as you see fit. All right, in our last section, we're going to be talking about cognition. And from what you might have remembered from the case, our patient had some difficulty with processing information. It just took him a little bit more time. He was fairly functional. However, our patient is a grad school student. So at some point, he does want to return back to grad school, which is going to be academically challenging. We want to make sure that we expose him to more difficult activities.
I want you to read this passage here. It's about motorcycles. It's your favorite because I know you like to ride bikes, right? So go ahead and try to read this passage here.
Okay. On average, about twice efficient cars. The first, Davidson, 1903. Tomato soup carbonator. Early helmets with cork.
Okay. What do you think made it difficult to read this passage here?
Well, there's just a lot of words for me to read. It was just very difficult.
Okay, so the words might make it difficult to read the whole thing. So let's try this other application and maybe that'll make it easier to read the words.
Okay.
Okay?
All right, Patricia. So we saw our patient had difficulty in terms of reading the words that were on the screen. What other strategies would you suggest, or what have you seen or learned in terms of cognitive retraining?
Yeah, so if you notice that they are having difficulty with executive functions, for example, then an example to help compensate for that or to remediate that is by using some type of like visual cue to make sure that they are following the task that they need to do for a certain example. Or we can help break down those tasks into smaller, manageable steps so that they are able to complete the activity as much as they can on their own.
Sure, which is what you're going to observe now. Another thing I want to add here, Pat, as you mentioned earlier, was you might, once again, eliminate some distractors, right? You can actually follow along with your finger to read each word individually. You can block out certain words if he's having difficulty with tracking. So we're not just looking at the cognitive component here, we're still keeping in mind whatever issues that he might have visually.
All right, so we're gonna try this different strategy where we are still using the same passage that you read earlier, except it is broken down a little bit more. So try to give this a shot and see how it goes.
On average, motorcycles are about twice as fuel efficient as cars.
Okay, good. Try this one.
The first Harley-Davidson motorcycle, built in 1903, used a tomato soup can for a carburetor.
And so far, our patient's doing extremely well. Once again, if your patient runs into difficulty, this would be a great time to, once again, get him to slow down, maybe even now use his fingers to read each word one by one. But so far, this strategy is working, so we're sticking with this path.
Okay, good. And this last one here.
Early bike helmets were lined with cork.
Okay, great. So what did you like about this strategy versus the first one we did?
For this one, I really liked it because it was easier to read and more clear, and I was able to read a little bit faster than previously.
Okay, good. So based on what you read, what did you learn or what did you get out of it?
Ooh, I think cars are twice as fuel efficient than motorcycles.
Okay. Are you sure cars are twice as fuel efficient as motorcycles?
Maybe motorcycles are twice as more efficient than cars.
Right, yeah,
Right,
exactly.
okay.
Motorcycles are. Okay, did you learn anything else?
Something about tomato soup and carbonara.
Okay. Do you think the tomato soup was used for something?
It was used for the motorcycle as a carbonator.
Yeah, the can, the tomato soup
Yeah,
can.
tomato soup can. Yeah.
Okay, good. Anything else?
Something about the helmet and built with something.
Okay. What do you think it was lined with?
Oh, it was lined with cork.
Okay, good. Great.
Okay, so as you saw in our last segment, our patient was reading and we were testing his comprehension, and he was doing fairly well, especially in terms of his reading, except that he couldn't remember certain details in the passages, which is why we had our therapist here cue him.
Right, and I don't know if you guys were listening to the type of cues I was giving, but in terms of the cueing, if I'm asking him questions, I want to make sure that I am asking him questions that aren't close-ended. That way it can really challenge his cognitive processing. It got him to really think about the passage that he read. So for example, the early bike helmets were lined with cork. He said something about helmets, and then I asked him, was it lined with something? That can help challenge his processing versus asking him like, were the bike helmets lined with cork? That's just more yes or no. So this helps challenge those functions even more.
All right, everyone, I hope you enjoyed our intervention video. As you can see that there's so many different things that you can work on with your client. They're going to present with any combination of deficits, and how you interact with them as a therapist is always going to be super important. I think the main takeaway here is to be really client-centered, to make sure that you are listening to what your client needs, trying to figure out what will make them the most successful. Even in that last piece where we talked about cognition, Patricia was having a discussion with him, and all of that is very important to give the patient more insight, give them the ability to know what they're good at or what they need to work on. So once again, what really separates us from just being pure rehabilitation professionals, what makes us occupational therapists is that we care about the person holistically, and we want to engage them in all of these different avenues. It's not just one thing, it's not just motor, it's not just sensory, but we are really just trying to focus on a plethora of different systems, because that's what they're going to need to truly rehabilitate and also habilitate. So thank you very much, and OT Miri, we'll pass it over to you.
So Dr. Michael Ng, thank you so much for, again, putting together all of these videos and clips and bringing your knowledge and your clinical expertise. I learned so much from you at school, and I was blown away. Really loved my experience during the CNS workshops. That was so much fun. I mean, not only did I make so many friends, lifelong friends, but I came away with that with just like a renewed inspiration and passion, and I just learned a lot. But through this video too, I learned things and noticed things that I hadn't noticed before. So I continue to learn from you. You continue to be my mentor, and I just really am grateful for you. I do have some questions, and I have questions both from myself as well as from students as well as therapists who have been sending questions through Instagram and through my YouTube channel. So if you don't mind, I would like to do some Q&A with you. Would that be okay?
Yes, that's perfect. Let's do it.
All right, great. So in the video, I wanted to ask you, so what type of handling are you doing? Is it NDT or is it sensory motor? Can you go ahead and talk about the difference and what you've been using there?
Sure. And to be honest, this is really just facilitation of movement. And when I say that, most therapists automatically think of NDT or some other type of sensory motor framework. But all it really is, it's just kinesiology. It's just movement science and using common sense. So I encourage therapists to think, how does the body typically move? And how can we facilitate those movements using primary muscles? And if that doesn't work, how do we compensate? So I'm not really using a special handling technique where I have to place my hand here or place my hand there and it's going to miraculously heal the patient. It's really all about just prime movers. So for example, in our case study, as you saw, the patient's internal rotators were highly active and his movement wasn't very efficient. So one of the first things I really wanted to do was just bring him out of internal rotation towards external rotation. His biceps were also highly active for elbow flexion. And so I just wanted to use his triceps to facilitate elbow extension. So it's really just common sense and taking the path of least resistance, which falls in line with a lot of sensory motor and neurodevelopmental frameworks, but I'm not really following a specific protocol. So for any student or therapist out there who is a little bit more timid or a little bit more you're afraid to utilize some of these handling techniques, I want to encourage you, if you have some understanding of kinesiology, you're going to be fine.
Great, thank you so much. Another question that I have is, and this is from one of the students actually, is there a story of a patient that's had a positive recovery outcome that you nor the medical team didn't expect, to which you attribute to the role of therapy, occupational therapy?
Gosh, a lot of people I've worked with had some really amazing recoveries, from going back to work to returning to professional sports to riding their motorcycle and even flying an airplane. And I've always considered myself extremely blessed that these experiences happened very early in my career because it showed me what occupational therapy can be. And from that point, I didn't really want to play it safe, or I primarily worked on ADLs, bathing and dressing, which are important, but I really want to focus on the true heart, which is occupation. But going back to the question, can I attribute the recovery to therapy? And I don't really know for sure. And I guess I really never know because the rehab process is so dynamic, and the medical team, neurologists, surgeons, rehab team, we all do our part. So I think when we come together, there's synergy and recovery becomes a lot more efficient. And OT is a big part of that, but I'm not arrogant enough to say it's only because of us or it's only because of the rehab team. In fact, it's really the patient who's the primary contributor, the ones who are most motivated, most diligent, and the ones who really take ownership of the recovery. For them, it's the sky's the limit.
Okay, so next question that I have is, I realize that the goals that each patient has is highly individualized, and it's unique to their own life experiences, but I'm curious to know if there's any single goal that comes up again and again, like, I just want to be able to use my arm again, or I just want to go out, I want to start eating out with my friends again. Is there any pattern, something that you've seen very frequently?
Yeah, about 99% of the people I work with always say two things. The first is, I want to walk again. The second is, I want to use my hand. And with number one, walking, recovery can actually be fairly quick. You saw in our case study, our patient was ambulating without a device. It wasn't perfect gait, but it was pretty functional. Now, when it comes to the hand, that takes a lot more effort to rehabilitate because you have all of these intricate fine motor movements that require a large amount of motor control. So it's understandable that most patients want to work on the hand. But sometimes it can be really frustrating if it's only about the hand. And sometimes I have to remind them that there are other components of therapy that are equally important. So for example, cognition, sensation, socialization, occupation, so much more, because not only will these interventions help them become independent, they can facilitate hand recovery as well. So to put all this into perspective, many therapists, they might get caught up in the motor system. They forget that motor control isn't exclusively movement. There's many different components. If I want to use my hand to hold a pen, there's some form of planning and organization, and that involves cognition. If I want to hold the pen without breaking it, there's tactile awareness and proprioception, and that's sensory. And if I want to write words to communicate, then that's language. I bring this up because, many years ago, a patient once told me that after his stroke, he thought his life was over. The only goal he had was to feed himself with the affected hand, which is a fine goal, but he didn't realize that he had the capacity to return to work as the main operator of his small business. He was an entrepreneur, and he was responsible for supporting his family and his employees. And suddenly, using the affected hand wasn't as urgent anymore because his other hand worked just fine. And when he realized that if returning to work was a viable option, he could focus on other things like executive functions. So to clarify, I don't have an issue helping someone rehabilitate the hand, but sometimes you have to encourage them to see the bigger picture. The rest of their life is not going to wait on that hand. If they have to return to work, raise a family, care for children, just engage in something fun, then how can we as therapists try to problem solve, optimize those strategies? And that's what makes us occupational therapists, not just a body part specialist.
That's right. That's right. Great. Thank you. And I have one last question, and it's for students that want to work in this setting. So actually I have two more questions. I'm sorry. For students who want to work in the neuro setting, what would you say is the greatest challenge that they face?
Yeah, probably the different types of deficits you're presented with and the never-ending combination of those deficits. And that's what makes neuro extremely fun, but also extremely challenging. No offense to orthopedics, I love ortho, but you can have a joint replacement that looks the same every time and you follow a protocol and the surgeon is awesome and recovery is predictable. But in neuro, you never quite know what you're going to get. Someone can have dystonia, where there's a lot of uncontrolled movements and they're shaking. And as soon as you put your hands on them, they pull away from you because they have hypersensitivity. And when you try to explain what you're doing, they don't understand you because there's aphasia. So you try to give visual cues, but that doesn't work because there's a perceptual deficit. So you simplify the process, but they're not paying attention anymore because they have an attention deficit. So it doesn't sound like fun when I put it that way, but I enjoy it because you're trying to solve a puzzle. And when the pieces start falling in place and the patient improves and they become more independent, then there's really nothing like it. It gives me chills when I think about it. It's almost magical. So it's very challenging, but in my opinion, nothing more rewarding.
All right, so we have one last question, and that is, aside from continuing education courses like CNS, how would you say that students or practitioners might best prepare themselves to work in the setting?
I think it's really important to expose yourself to different settings and different therapists and different therapies and techniques. I think that's a good strategy. When it comes to neuro, to be honest, it can get very political and divisive. There are therapists who swear by one single technique and that's the be all end all. They'll use it all the time and they won't use anything else, regardless of the patient's progress or lack thereof. And that's a real shame and a disservice to our clients and our professions as a whole, because when it comes to neuro and any other OT setting, I don't think you should be just closed-minded. There are so many different types of interventions and even new ones like EMG, virtual reality, robotic therapy, to name a few. Granted, not all of them will work for every single patient, but I strongly believe it's our job to give it a shot and try to optimize the program. And I think the most effective therapists are the ones who are brave enough to try different tools. They don't have a hidden agenda that endorses one technique over another. All they want is just for their clients to get better. And I think most importantly, you have to love your work. And I'm not talking about your job, your place of employment. I'm talking about your career, your body of work as an occupational therapist. And this can be in any setting, as long as you feel challenged and fulfilled. You'll have those moments where you think about work all the time, and not because you're stressed, but because you can't wait to try this new idea or this new intervention or occupation. You think about it all the time because you just love it so much. So that's my advice to new grads, students, entry-level therapists. It's okay to explore different populations, different settings, but I think when you fall in love, that's the real thing.
Can I just be your student again? Where can I go to be your student again? I miss learning under you. I miss learning with you. And this was so insightful. And again, I know I say inspiring again and again. And if you're watching this, you can see that I was smiling the entire time. This was me at USC when he was around. This was me when, you know, I was taking the course at CNS, because I love to learn. And I love to learn from people who really know what they're talking about. And when it comes to Dr. Michael Lang, it's just a really good balance of knowledge, clinical experience, but he also brings deep passion to this work and the work that he does. And you can see it. You can see it when he talks. You can see it through the philosophy and the values that are embedded in everything that he's saying. And so I'm really grateful for you, and I'm grateful for our time together. And I really hope actually that this isn't the first and the last. I have a feeling we're going to get a lot more requests for you after this video. So maybe we can do more videos together. But this was wonderful. Thank you so much for everything that you've offered.
Great. Thank you, Mary. Excited to work with you again.
Okay. Bye, everyone.